Okay, should we get started with the rest of the questions? So for anyone who doesn't know me, I'm Carly. I'm a PGY2, almost 3. Thanks to Paul and Dr. G for their help with these. Let's try and make this interactive. Who wants to volunteer for the first question?
Pick someone will be more interactive.
Trevor. Okay, I'll read it for you. A 65-year-old female recently diagnosed with lymphoma presents with nausea, abdominal pain, extremity pain, and confusion. What do you think her electrolyte abnormality is?
I'm gonna say hypercalcemia. C. Final answer.
C is hyponatremia. All right, Trevor says B, hypercalcemia. He's right. So patients with like breast cancer, lung cancer, multiple myeloma, and lymphomas, they'll also often have hypercalcemia. And it's because their cancer causes like a pseudo hyperparathyroidism, causing calcium to be released. And you think of that mnemonic that's like stones, bones, abdominal moans, and psychiatric overtones. So patients with a lot of vague complaints where you're like, what's going on? All right, let's get a junior to do this one. Edwin.
1 month later, the 65-year-old returns to GP. She had her first chemo last week and is having similar symptoms: vomiting, lethargy, muscle cramps, no longer lab shown now. I'll go with C.
Okay, he's going with C, hyperkalemia, hypocalcemia, and hyperphosphatemia. And that's right. So kind of the diagnosis I wanted you guys to think about here was tumor lysis syndrome. So these are usually patients that have recently started their chemotherapies. It's usually like a lymphoma or like a hematologic malignancy, but it can be solid cancers as well. And the way you remember it is just like, you're literally like bursting cells open. So that's where the hyperkalemia comes from. And that's where the hyperphosphatemia comes from. The tricky part for me to remember is always the hypocalcemia, but you're getting that because your phosphorus is high, and so it's binding all the calcium. So that's why your calcium level is low. And you just usually treat these patients with a lot of fluids, but you can also give like rasburicase to help with this. Okay, maybe someone, let's see, who do I see on the video? I see Wesley Chan on the video. I'll read it for you. A 55-year-old male, he has diabetes, CKD, says he's had really black stools lately. His hemoglobin is 6.4, his platelets are 250, BUN 130, creatinine 7. We're obviously going to give this guy blood, pantoprazole, but what else should we give him? Wesley, can you hear us?
I'm assuming D, desmopressin.
All right, desmopressin. Yes, that's right. So the trick here was that this patient had CKD and uremia, and the uremia leads to dysfunctional adherence of platelets. So the idea is if you give desmopressin, it will release your von Willebrand factor, and then your platelets will function better. Okay, let's see. Faraz, a 34-year-old male, he has sickle cell disease, he has sudden onset, right arm and leg weakness. You call a stroke code, his CT head is negative. Dr. Law is like, TPA, but, oh wait, but that's not the answer. What would you rather do? B, exchange transfusion. Yes, you guys are crushing it. So basically the idea here is that their cells are all sickled in their brain, and that's what's causing the ischemia because the blood flow is blocked. So you want to do an exchange transfusion. There are fancy machines at places where you just hook them up, and I don't really know how it works, but you can also do it manually, and it's basically just replacing their blood volume. So bleeding and then giving blood and trying to like match the inputs and outputs. But they generally recommend you don't do this unless you're an expert at this.
I talked to both neurology and the sickle cell team about this yesterday.
Oh,
Yeah, no, I told neurology, I was like, so do they need exchange transfusion? And they're like, no, for what? And I was like, because they're sickle cell. They're like, oh, is it different? So it was interesting that they were unaware. And then when I asked the sickle cell team, like, if she has a stroke, what do you guys want to do? Do we need an exchange transfusion? They were like, well, we'll just do whatever neurology wants to do. And then I asked about exchange transfusion. They actually said it's not to treat the stroke that they're having, it's to prevent them from having another stroke, which I thought was an interesting way.
Shane, I have a question. Is it the same neurologist who?
I sent it to the group. That's a paradox.
so I guess maybe they're not like the ischemia is already there and you just need to prevent it from worsening, maybe was what they were thinking, but maybe we should talk to our consultants about this.
Yeah, but it's true. It doesn't fix the current stroke, right? Just like almost really nothing fixes the current deficit problem. The sickle cells are there, they're going to be there, it's going to cause ischemia. But you want to prevent other sickle cells from infarcting other areas, right? Because whatever is going on in the system is already causing infarction, so if you exchange that, try to prevent any more cells from falling. They'll also know that sometimes you're the smartest person in the patient, so remember that. That's a good life lesson.
All right, let's go to the next one. Okay, Lisa, this question is for you. A 24-year-old female bounces back to the ED. She was seen 2 days ago. She had a UTI. They discharged her home with nitrofurantoin. She says, my dysuria is gone, my fevers are gone, but I'm like really, really tired. What's going on?
G6PD.
G6PD. Very good. So basically in G6PD, your cells are not very good at repairing themselves against free radicals. So kind of any little stressor can tip them over the edge. So certain drugs do this, but also infections do this. So just something to figure out, to think about. Yeah. All right. Camilo, this one's for you. A 47-year-old with breast cancer comes in with dyspnea and chest pain. She has a PE. What anticoagulation are you going to start her on? Okay, he's going heparin. So this was kind of a trick question. So I think in med school, a lot of us were taught about low molecular weight heparin, and those were the most studied anticoagulants in cancer. But actually, really recent guidelines have come out that say DOACs are actually just as good as low molecular weight heparins. So probably on a test, you would still pick the low molecular weight heparin, but if it's real life or low molecular weight heparin is not an option, then a DOAC. That was a tricky one. Okay, let's see. Ryan Walsh. A recently discharged patient comes to the ED with this rash. What medication were they taking in the hospital? It is heparin. Good job. So basically in this rash, we're seeing like purpura. So in heparin, this was supposed to be a question about heparin-induced thrombocytopenia. So you can calculate their 4T score, all of those things we did on medicine. But basically, they have really low platelets, and so they're going to have bleeding.
And I think it also translates to low molecular weight. So if they had heparin-induced thrombocytopenia, I wouldn't take a chance in getting them low molecular weight. I would do something completely different. DOAC or find the Heparin.
Okay, let's see. Sabby, would you like to answer this question? a 17-year-old male with hemophilia A. He comes in as a level 1 trauma code. He hit his head when he fell off his bicycle, and he's acting differently. This is his CT head. What treatment would you give him?
Yeah, hemophilia A, I think you give factor 8.
Yes, good job. So hemophilia A is factor 8, and hemophilia B is factor 9. So we can remember our coagulation cascade, and you're just replacing what they don't have. Both of these are part of the intrinsic pathway. Yeah, that's it.
The only thing I would say about that, and on the test as well, is that you don't want to wait for the result of the CAT scan to start giving them factor 8. So if they had significant head trauma and you have the factor 8, sometimes they carry it with them. And they know how to give it, or their hematologist can get it for you. You probably should start at least half the usual dose prior to the CT.
Yeah. Yeah, I was reading about some patients actually carry like their own factor 8 or own factor 9 that's like been taken from their own blood, which is really cool. That's really cool. Yeah.
And they may need, often with head trauma, they may need repeated. So you want to admit them, and they may need, and then in conjunction with the hematologist, you may have to repeat in like 8 hours or so the factor 8. So, but once to get the initial, you want to be in contact with their heme person and see, but always admit them for repeated doses for something like head trauma. And remember that you're going to for something like head trauma and with a hemophilia A, you have to assume they probably have any factor 8. So you're going to completely go up to 100%, right? As opposed to something like a hemarthrosis, you may only replace 50%. But here you're going to go to 100% for the
It's the same life-threatening things that we talked about for reversal for those blood events. And for factor 8, it's just 1 per kilogram. And factor 9 is like 0.5 or 2.
Yeah.
You
get twice as much, whatever. Twice as much. And you should know that formula. They like to ask you that on the test, how much you're going to get based on kilograms.
It has to be the 100%. Like it has to be a test of the matches. So I think they're technically asking us one of the other indications.
All right, Calvin. This one's a hard one. Which patient should receive irradiated red blood cells? Something I don't really think about that often. D, good job. So basically the idea behind irradiated red blood cells is that there are no T cells. Every red blood cell transfusion has a few T cells, and in a normal healthy person, their body just kills these T cells and it's not a big deal. But in people who are immunocompromised, they don't have the ability to fight off these T cells, so those T cells can cause a reaction in their blood. The other situation where this happens is when people's family members donate blood to them, because your body doesn't recognize it as foreign, it recognizes some of the HLA antigens on the cells. So it thinks it's its own cells because it partially matches, but it doesn't. So I don't know what situations when a family member would be giving someone blood, but if you're ever in that situation, or in our like organ transplant patients, something to think about.
Something else to remember, since we didn't get to all the questions, so Carly's going to send it out, is another place where T cells, not about irradiation, but where T cell problems is the CRS, cytokine release syndrome, right? Where the T cells get activated by a monoclonal antibody or by CAR T cancer therapy, and then they attack, right? They release stuff from the T cells, and those substances attack you, and you become hypotensive, febrile, and the treatment's different. Obviously, you're not going to irradiate the whole body, wipe them out, but there something to know about more and more, because they're using these, these monoclonal antibodies and the CAR T therapy for treatment for lymphomas and other things. So just know the cytokine release syndrome, although I haven't seen a question on the board yet with it.
All right, last one, Natasha, come on, take us home. Which of the following is consistent with DIC? D, yes, good job. That was good test taking skills. And DIC, I think you always have to just kind of go through it in your head, like things are getting used up, things, you're clotting and you're bleeding at the same time, basically. So your coagulation cascade is going into this kind of vicious cycle. So yeah, your fibrinogen goes down because you're using all of the factors. Your PT and PTT go up because all your factors are gone. Your D-dimer goes up because you're clotting, and then your platelets go down because you used all the platelets. And that's it. Thanks
One
to
thing
everyone.
remember about when it's platelets alone that are affected, PT and PTT usually won't change. It's a pure platelet problem. And then the best test, we don't do that here unless you really ask for it, is a bleeding time. If you're looking for platelet dysfunction, PTs and PTTs will stay normal for that.
Perfect. Any questions? Cool. Thank you to everyone who answered questions.